I guess, what are you willing to sacrifice? How much is that muscle growth worth to you? Is it worth your libido? Is it worth your health? And those are things that you got to ask yourself when you want to just continuously jack up your dose of testosterone.
While testosterone can help you build lean body mass, just having a high testosterone does not predict that you have a bunch of muscle in your frame.
The testosterone, a super physiological dose, is not like a Band-Aid to correct all your other bad behaviors, your bad diet, your bad training, all that stuff.
Like your body most likely has an optimal level that it wants to be at. And from where you're starting to that optimal level, every point that you get closer to that optimal level of low risk, high reward, it's a little bit better, a little bit better, a little bit better. Now at your physiological saturation rate norm, every step above that, you actually start to make a turn for the worse. Problems that mirror a suboptimal guy when you're at super physiological levels.
Yeah, trying to cure the world one patient at a time of testosterone deficiency. Hey guys, welcome back to another episode of the Vitality Code podcast. I'm Dr. Jason Farrah, alongside my co-host, Dr. Jeffrey, aka Wonderbeard Farrah.
Wonderbeard.
Yes, we got Wonderbeard and Wonder Boy, and the well chiseled young Dr. Sokolowski. How you doing, Chester?
I'm always good like grandma's cookies. Thanks for having me on.
Oh man, cookies. Grandma's cookies, baby.
I'm not familiar with that one. I might have to steal that.
Does Grandma Sokolowski put some proats in her cookies?
No protein oats in the cookies. No, my old grandma, we called her Bumpa. She used to work at a hospital.
What'd you call her?
In the baker. We called her Bumpa because we couldn't pronounce grandma.
Bumpa?
Bumpa.
Is that a Polish thing, or?
I have no clue. It's one.
I think it means one of my daughter's friends calls their grandfather Bumpa. So maybe that's weird. I'm having deja vu here.
Weird. World. They stole it from us.
Yeah.
OG Bumpa. But she was a baker at the hospital, so there is nothing protein, nothing healthy with her baked goods.
So it was just delicious, though.
Oh yeah, yeah, it was
hella delicious. What was your favorite baked good that Bumpa makes?
Honestly, my family, we're kind of from the projects, so we had just sugar bread. We speaking of Wonder Boy, we had just a good old slice of Wonder Bread. You put some butter on it and put some sugar on it, super cheap. And then we call it sugar bread, and you just kind of funnel that in.
Wait. You got a raw piece of bread that you just put some sugar on?
Yeah, it's a piece of butter with some bread, and you sprinkle sugar on it.
Do you cook it?
Butter.
No.
The butter makes it healthy.
Yeah, it's got, moofas and poofas kind of ish.
Moofas and poofas.
That
Jeff,
sounds delicious, actually.
Why don't you throw some knowledge on old Dr. Sokolowski there about the sugar crisps?
What's a sugar?
Oh, yeah, that would be...
Talk about homemade ghetto baked goods.
So just we still make those at my house, if I'm remembering correctly. Just taking a flour tortilla, you mean, and cooking it in oil, and then you put some cinnamon sugar on it.
Kind of bubbles up, and man, it's good stuff.
Yeah, same kind of deal. Get that Schwann's delivery of mint chocolate chip ice cream. I tell you what it did to my cholesterol. Nothing. I'm a champ.
Well, you're a genetic cholesterol freak. Look at that guy's LDL. He's a genetic freak. I wish I could be like him.
I got to take that one to the bank because
the 2024 cholesterol champions introducing you to Dr. Jeffrey Farrah.
I wonder what would happen if I took a statin. I wonder if it would just.
Good God. Would you shrivel up and die? I mean, there would be no cell membranes.
Zero
anywhere.
cholesterol.
Yeah.
I wonder if there is any disease process from absence of cholesterol. Maybe that's why my testosterone was garbage.
Maybe. You didn't get that beard from nowhere, though. That's an androgen fueled beard if I ever saw one. Look at that, baby. You had to have it one time. So speaking of testosterone, Chester, last time we had kind of mentioned, and you promised to come back, and I appreciate you doing so, and tell us we talked about cholesterol, why it's important, what should we do about it, what should we not do about it, what does it mean, and more what's the context in the universe of risk factors that we may or may not find ourselves in, and that seems to be a big part of it too. But what about these people that are taking advantage of Vitality Telehealth Services, by the way, which the episode is. Forgot to introduce that part of it. Sponsored by Vitality Telehealth, but or in our respective clinics. Should they be worried about testosterone usage and what it does to cholesterol? And tell us a little bit about, if anything, what the literature says.
Okay, so we'll start with a continuum. We'll start with low T, first of all. Obviously, low T, low testosterone, can have a number of deleterious health effects. And one of them is impaired HDL function. So what the HDL is going to do, it's going to sort of scavenge your arteries for some cholesterol and then take that back to the liver. So it's going to essentially clear the cholesterol from your arteries, and that could be potentially advantageous to avoid atherosclerosis. So low testosterone is actually associated with impaired HDL function. Low testosterone also sort of has more of a higher risk in general of cardiovascular disease, and it could manifest through a number of different areas. We mentioned the impaired HDL function. We also could have with low T body composition that's not exactly best suited to combat disease. And what I mean by that is more fat and less muscle could be associated with low testosterone. So a higher body fat that can promote sort of a pro-inflammatory environment, less skeletal muscle. Skeletal muscle is not just, it looks good and helps you, move around and lift stuff up, but it's also an important metabolic organ. So all the sugar you eat can be taken up in skeletal muscle. And if you have less skeletal muscle, you're going to have less organ to store glucose, so you could have some elevated blood sugar.
You've got a great
muscle mass. You could have some of that insulin resistance.
You got a great point there, and that's what I love. To give a shout out to Dr. Gabrielle Lyon. Have you guys seen this female physician in the IG universe at all? She's a big proponent of muscular development and treating muscle as an organ, building your muscles up as a way to improve your health. And you're absolutely right, Chester. That's not enough is said about that, because what we know about a higher fat environment is the adipokine signaling. And then on the converse side, the muscular cytokines. So if you have a body that's optimized in terms of muscular function and quantity, quality, etc., you'll have chemical messengers floating on your body that improve the health of end organs, laminar blood flow, less inflammatory mediators that are bad, so forth. If you have a body that's comprised more of unhealthy subcutaneous or especially visceral fat, you'll have adipokine or chemical messaging systems in your body that are going to, in and of themselves, just from having more fat in your body, increase inflammation, pro-inflammatory environment, hyperpermeability of vascular junctions. Just leaky vessels, just a mess. So you're absolutely right about that. That's fantastic. And if you've got a compound here that's an antioxidant that increases lean body mass, that promotes those things, especially at safe levels, it seems to me that would be beneficial in terms of your overall cholesterol burden and the metabolism and processing of it. Would you agree, Chester?
Absolutely. And they've even done studies in older men with sort of lower end of testosterone, and they've given them TRT therapy. And it's also helped reduce markers of oxidative stress. And they were largely mediated through those increases in body composition, more muscle and less fat. So you could see some measurable markers, some objective measures improve with TRT therapy in terms of your insulin resistance, your oxidative stress, all those little various things that are going to kind of lead up to CVD risk and developing atherosclerosis. So we're going to see improvements in those markers to prevent it.
And that's a good clinical study, and there's good epidemiologic studies out of the VA healthcare system. And guys under testosterone under 200 have more risk of cardiovascular disease, stroke, diabetes, etc. Interestingly, too, that correlates with murine models or animal models, which I know, it's somewhat dicey to infer exactly one correlation or anything like that, but or even causation. But it's interesting to note that male rats that are not that are neutered, is it neutered or spayed? Anyway, they have their testicles removed. Let's say that
castrated
at birth. They form atherosclerotic lesions much faster and of a higher and worse intensity or degree than do their counterparts that are not castrated. It's very, I mean, reliably so in a linear relationship. It's very interesting. And so that is a model of the continuum of testosterone's impact on both blood flow and cholesterol. It's very interesting. Thank you for bringing that up. What about if you were on super physiologic testosterone?
Okay, so you often hear, bodybuilders, they're juicing and they have premature deaths and it's cardiovascular related. There are some negative effects that a super physiological level of testosterone can have on testosterone or on cholesterol, excuse me. The first one would be super physiological testosterone can increase your LDL, and it does this a few different methods. It's going to inhibit the 7-alpha hydroxylase enzyme. So what this is an enzyme that's going to help you produce bile acids. And bile acids help remove cholesterol from your body. So you're going to inhibit the enzyme that makes bile acids. You have less bile acids, and then less bile acids, less cholesterol removal. You could see an increase in your total cholesterol. Additionally, supraphysiological testosterone is going to increase the expression of HMG-CoA reductase. So it's sort of the same enzyme that statins are going to act on to inhibit, that's going to limit the synthesis of cholesterol. Supraphysiological testosterone can also act on that enzyme, increase the expression of it, then you can have more cholesterol and potentially more LDL. And then also supraphysiological testosterone, it's going to have increased hepatic lipase. And what you also have is, in addition to your LDL, you have HDL. HDL is different forms. There's HDL2 and HDL3. HDL2 is the big guy that's going to grab the cholesterol in your arteries and help return it to the liver to then get rid of it. So you have increased hepatic lipase. This can help sort of break down those fats on the HDL2. It can then become a smaller HDL3 and then converted to a pre-beta HDL through the LCAT enzyme, and then you can actually recycle that back into the liver, and then your HDL is gradually going to go down. And that can have sort of negative effects. And you guys have talked about in your clinic how people on super physiological steroids and a whole bunch of androgens, just their HDL is absolutely nuked. It's in the teens, and that is the androgens having that effect to potentially, you kind of get those
breaking it down from HDL2 to HDL3. That's the mechanism by which it's doing that, basically?
Yeah, that is the specific mechanism. So your large HDL2 that is going to essentially grab a whole bunch of that cholesterol that's floating around and help kind of clear those plaques and such. It is going to be converted, cleaved into HDL3, a smaller version, and it's just not as effective. Additionally, it does harm your LDL because we have the increased hepatic lipase. So your LDL, what you want is kind of big HDL molecules and big LDL molecules. It can kind of cleave and sort of shrink your LDL a little bit. Then you can have smaller, more dense LDLs. And then those are a little bit more likely to kind of sneak through those compromised endothelial junctions and then get into your arteries, those smaller LDLs, and then contribute to that plaque buildup. So it has a number of negative effects on the LDL and on the HDL, and could potentially promote a sort of pro-atherosclerotic environment through reduced HDL, elevated LDL, and not just elevated LDL, but sort of more small, dense LDL, which are going to be the more atherosclerotic of the LDL, that are more likely to sneak into that endothelium, become oxidized, and then contribute to that plaque buildup.
Chester, when you're saying super physiologic, are you referring to dose, or are you referring to what's that?
All the gear, all the super, super high doses of testosterone. So we're not talking
not necessarily the level. Are you saying all synthetics, or are you saying testosterone itself?
Testosterone, the level of testosterone.
So not necessarily the dose, that we're talking about the subsequent physiological response in the body.
Yeah, the studies I saw, they define
it could be the dose.
The
dose is then going to trigger something that your body would not naturally produce, so above your natural range. So you can inject a synthetic and get into your natural range of testosterone,
right?
If you just dose it properly. But I'm talking about the bros who want to do all the gear and all the trend and all the, just a large bolus of androgens to increase above what their levels would be. Not just potentially with more testosterone than physiologically possible, but also more adding the other androgens as well. We can have some of those negative effects as well.
Yeah. Jason, do you see that in your clinic? I noticed there's what I call a thumbprint to testosterone. It's like some guy might be doing 100 milligrams of testosterone, and another guy might be doing 200 or 300, and yet their levels, their physiological levels, serum levels are the same. And that's why I guess I was asking is the dose is so independent of an individual, as opposed to, I think some of the problems with the research is it's just all standardized dosing.
Yeah, I mean, yes, because that leaves out pharmacokinetics, and this is the problem with a lot of the research in testosterone too, is that it's not standardized, because I don't think a lot of people understand what they're talking about when they talk about it. And frankly, I would be one of those people had I not been in this world for many years like you guys. So, yeah, I mean, the first thing comes to mind is volume of distribution. If you've got a 5'3", 140-pound guy, and you put a cc of testosterone, cypionate 200 milligrams a mil in that guy, versus a 6'5", 285-pound guy, just volume distribution alone, you're going to see different blood serum levels. Then there's metabolism that seems to be unique. Then your cytochrome P450, etc., liver metabolism of it, and what your genetic, is it induced, is it not? Have you been drinking? Are you not? And
I find that volume distribution seems to be a big major factor in my pellet patients. Less so, I would say, in my injectable patients.
Mm-hmm. Yeah, it does. I absolutely. That is bizarre that there's more of that with the pellets and less of that
almost exclusively for pellets. Like I rarely find a smaller guy, if you want to use that term, less volume, less mass, that takes a higher dose than a larger gentleman would talk about pellets. But injectables,
it is bizarre that the dose, you could almost start everybody at X amount of twice per week or something of testosterone cypionate, because reliably that there's a narrow window of dosing, but the pellets, there's a wide variance.
Mm-hmm. Mainly dependent on their mass.
The one thing that I saw that was interesting too was, this is really interesting to me, Chester. It looked like testosterone is an antioxidant, but there seems to be a limit to that, where if you're doing these mega doses and or super physiologic testosterone, perhaps, maybe it's even time, I'm not sure, but how long are these doses that elevated that look like your research showed, your collection of the research out there show that maybe oxidative stress increases and nitric oxide production decreases. That blew me away. Am I reading this right? Is that true?
Yeah, you can have increased oxidative stress, and especially with the super physiologic. So above, it doesn't matter essentially the doses, whatever that would increase testosterone to way above what the male could naturally produce for that specific person's body. And once you get to way above what that natural male can produce, then you can see those deleterious side effects in terms of the cholesterol, in terms of the increase of oxidative stress, in terms of the increase in blood pressure, and then that would obviously translate to
blood pressure.
An increase
that was a big one too.
Endothelial damage, and then potential atherosclerotic risk.
Right, a non-laminar flow and hypertensive injury to the intima, reducing the ability of the intima to be in a healthy homeostatic state, and I see this on guys that are in high doses of testosterone, and they almost want to be on more because they'll have I don't know, Jeff, if you see this, but some kind of not frank erectile dysfunction, but just reduced quality of erections, and obviously
the higher they go into super physiologic.
Have you noticed that?
I mean, I tell patients when I'm explaining to them before we even start and all that, I say, like your body most likely has an optimal level that it wants to be at. And from where you're starting to that optimal level, every point that you get closer to that optimal level, it's low risk, high reward, and it's a little bit better, a little bit better, a little bit better. So say you're at 300 and you're going to 800, 300 to 400, 400 to 500, 500 to 600. Those are all steps in the right direction. You see benefit, you see improvement, low risk, high reward. Now at your physiological saturation rate, norm, benefit, every step above that, you have a less benefit. You have a higher risk and less benefit, right? And then if you keep going down that, you actually start to make a turn for the worse.
Yes.
And you're likely to have problems that mirror a a suboptimal guy when you're at super physiological levels.
Yes.
Those two kind of correlate, these excessive, and it makes sense. I tell them, you're going to feel this, right? You go from 3 to 5 and 5 to 7. You're like, well, hell, from 7 to 11 and 11 to 15, it must follow that same line. And I tell people, we're trying to get to the point at which you feel the best and have the zero or the least amount of side effects, and hopefully zero side effects, or least management is how I term it. But super physiological levels sometimes can also feel like the low levels in terms of how much 100%. Management you have to do. And
I absolutely recall early on in my own testosterone journey that I had this moment in time where I was like, oh my gosh, I feel like my testosterone is horrible. I got to take a shot, or I just feel so low. Took labs first, trying to be disciplined, to make sure I was looking at what I was doing, not flying blind. And I was way high. And I said, oh my gosh,
interesting, isn't it? Yeah.
Yeah. It would just, and so to see this though, that maybe oxidative stress increasing, we know if you're getting more and more hypertensive, you're going to have non-laminar blood flow and internal injury from hypertension. But then, and seeing that the nitric oxide decreases is so counterintuitive, and it's so hard, I have found, to steer guys in the right direction, not because I don't want to, not because I'm not trying. It's just that it's so hard to overcome that bias of if a little is good, more is better. It's so hard. Do you find that in your clinic too, that guys are just naturally resistant to it, or maybe it's the people that are coming in? I don't know what it is, but
I think the way I explain it to them, and I think the way I understand it is it makes sense logically, right? If 3 to 5 is better, and 5 to 7 is better, and 7 to 8 is better, and maybe their peak point's 1,000, I don't know, and they go from 7 to 1,000, it just makes sense.
Right, I guess the evidence
keep
is
going higher, right?
Yeah, for a while that does pan out, right? A little is good, yeah.
Yeah, it just doesn't make sense to guy that a low or a high testosterone would be a bad thing when raising it was a good thing. But
right.
Yeah, I think it is hard to wrap it around. In your experience, Chester, in the gym, is it always considered better to be higher by a non-medical person? Is that like a universal truth, or do you think that's changing, or what's your thoughts on that?
I think that there's different testosterone levels for different goals. Like if you want to do the optimal dose to maximize muscle growth, it is not the same as the optimal dose to maximize libido. I mean, like bodybuilders,
it's true.
It's interesting. I'm going to say bodybuilders blast gear, and a lot of them have really low libidos or erectile dysfunction or something like that. And it goes back to show you that there is some endothelial damage. There is excessive oxidative stress with those incredibly high super physiological doses. And if you're going to compound, black market stuff where who knows what the purity is, the contamination, you're going to bring in other androgens, masteron, trenbolone, things like that. You're just potentially adding to the problem and exacerbating the potential damage that you can have from an already super physiological testosterone. But that might be a little bit better for muscle growth. But it's like, how much, I guess, what are you willing to sacrifice? How much is that muscle growth worth to you? Is it worth your libido? Is it worth your health? And those are things that you got to ask yourself when you want to just continuously jack up your dose of testosterone.
And the other thing too is, what role is other genetics playing, and technique and knowledge base? That's why I love the PhysiqueU app and the different projects that you have out on social media to teach people how to perform exercises the best, the most functional, the safest, and also to get the best gains from what you are doing. Because it is true that while testosterone can help you build lean body mass, just having a high testosterone does not predict that you have a bunch of muscle in your frame. I see guys all the time come. In fact, of the people that I've ever tested their blood levels, and the great white buffalo, like you get somebody that comes in that actually has a testosterone endogenously. Normally
you're 800,
800, 700, almost as a rule. They're like these skinny, non-muscular dudes. And so it's so funny because you think, oh, high testosterone, big muscles. No, not necessarily at all. So you've got a guy here with a PhD in exercise science and knows this stuff, has done it, bench research on muscle and the skeletal muscle in the body and the way to put on muscle, maximizing ways to hypertrophy the muscle. And if you're taking advantage of PhysiqueU and learning those techniques, and then you have a optimized but not outrageous testosterone, that's going to do you a whole lot better. Some blasting of all these crazy gear and all this stuff in other words, that's not going to do it in and of itself. Yeah. It just
Jeff,
isn't.
I think I came to you like 4 years ago, and I was like, I've lowered my dose of testosterone, but I'm making the most gains ever. It's because I'm sleeping better. My digestion is better. Like all the other things are essentially optimized in my life to then facilitate the muscle growth. Whereas if you're doing crazy levels of super physiological drugs, some of those other elements could be thrown off in terms of your sleeping and your eating and your stress management and your hypertension and all those little kind of details that really enable you to essentially live your best life and maximize your training, maximize your muscle growth. I don't want to say it's cheesy because we have vitality telehealth, but maximize your vitality and your vigor. If you're doing those super physiological levels, all those little other elements, the details could be thrown out of whack, and that could slow your muscle growth. So I would say having a solid knowledge foundation of training in terms of what you're doing, combining it with a good, a healthy, higher amount of testosterone, that's the sweet spot for gains. It's not just blasting the maximum amount of testosterone you can have. I would say 99% of the people who are doing gear, super physiological testosterone, should not be doing that, just because you see issues in their lifestyle, and those are the bigger issues that are going to limit gains. The testosterone, a super physiological dose, is not like a Band-Aid to correct all your other bad behaviors, or your bad diet, your bad training, all that stuff.
So
I feel like, unfortunately, most of the bros view it that way.
Yeah, I tell guys, you think more testosterone is going to be better feeling and, it's going to be better muscle, but actually the higher you go, the worse you're going to potentially feel. And I don't want to then treat you with a Band-Aid. Like if you're pushing and you're asking me to dose you and push these, or you're running gear unbeknownst to me, and you're doing these things to push your testosterone, and therefore, squashing your HDL and or raising your LDL, and then now we're going into a statin. But the reason we were doing that, or the reason we need this statin to alter your cholesterol, is because of something that you're causing. It may be better to just not do the causative thing than to continue to do the causative thing and add a statin. And I think statins make a good. I think they're prescribed for a lot of reasons, but I think one of the things is they're so well researched, they're so well accepted, they're inexpensive. Most insurance plans cover them. They, to a degree, are effective in what they do, and so I think it for those reasons it makes an easy choice. It's hard to parse out how much of that is driven by the pharmaceutical industry and how many billions and billions of dollars are made yearly off of statins. But there is some definite pros, or definite reasons, I would say, why statins are used so commonly.
So Jeff, when you're seeing somebody in the clinic like this and you're worried about their cholesterol, do you jump right to statins? Or let me say this, if you don't jump to statins or medicines, what lifestyle issues or what preventative medicine type of framework do you apply to their situation before you go right to statins, if it's a patient that you deem can afford to wait?
If I deem it's a patient that can afford to wait, we're going to look at like you said, the lifestyle ones that we talked about prior to. But we may look at just the efficacy or the applicability, or are statins the best one? Maybe we can improve your diabetes. Maybe we can improve I'm thinking of one patient individually early on in my career who just had a real strong desire to get off statins, got off the statins, got him exercising regularly, got him normalized metabolically in terms of his insulin and glucose levels and his diabetes scores. And that alone was enough to fix his cholesterol, and taking him from a suboptimal testosterone. He was getting injections locally here on I think once every 2 weeks schedule, because that's what the insurance would pay the physician to administer in office. And so each visit was a reimbursable visit for the injection. So he had to come to the office every 2 weeks, get an injection. We put him on pellets, got him exercising, and that was enough to lower his diabetes scores and lower his cholesterol by virtue. And still to this day, almost 5-6 years later, his cholesterol is almost a non-factor. So I think you can manage it other ways. Not to say that statins don't have their place, but there are other ways to manage it.
Chester, what do you recommend in terms of modifiable, to basically, I guess in my mind, you want to improve the endothelial function and limit endothelial injury, in addition to lowering cholesterol. What things can you do to do all three of those?
Well, I would obviously say diet and exercise. We can have like a whole different podcast that is just we break down all things diet and all things exercise. And I'm sure people have heard, like you need to start exercising, you need to start exercising. If you're not exercising, one, you obviously know it has tremendous benefit. But two, I would say if you're trying to get in the habit of exercising, don't just kind of go, gung ho and think, all right, I got to go do like 75 hard and you just jump into it full swing. I would say take baby steps, take progressive steps. And one thing that I've found in people that can essentially start a more active lifestyle and then work up to consistent exercise is just having a step goal, like a step goal per day. Like, all right, I'm going to get 6,000 steps this week. Next week, I'm going to get 7,000 steps. The week following, I'm going to get 8,000 steps. And you kind of just build onto that. Then I'm going to hit the gym, 8,000 steps, one workout a week, and just kind of work your way into that. And I feel like once you get that object in motion, it's going to stay in motion, and you can have your exercise routine going. Then maybe start to look at some of your nutrition. Then look at your other various lifestyle factors. Am I smoking? Am I exposing myself to, an environment with pollutants? Could it kind of minimize oxidative stress that way? Am I reducing my stress as best I can? Stress can contribute to, sleep, negative sleep. Negative sleep can deleteriously impact your body composition, your insulin resistance, sort of lead to a pro-inflammatory environment, to lead to more markers of oxidative stress, more markers of inflammation. So there's a number of different things that you can do, but I would say exercise is a big one, nutrition is a big one, and you don't have to just go full gung-ho into a 180 lifestyle change. You can literally start with baby steps, like having a step goal.
Yeah, consistency, I think, is the thing that matters, or that's what I've been trying to, as of late too, I've been changing my talk to patients. Like, I think we say, all right, well, we'll recheck your levels in 60, 90, whatever days. I'm like, let's work on lowering your cholesterol in 2 years. Or let's work on losing 10 pounds in 2 years. Consistency, I think, is been my more recent focal point, right? The statins will lower your cholesterol today. And it'll work really easy and it'll work really effectively. Potentially, there's some side effects that we want to stay away from or that may affect you. But if we change our framework a little bit and we talk about let's institute some lifestyle patterns for the next 1 to 2 years and just framing that right off the bat, I don't need you to go to the gym 5 days this week. I need you to go to the gym for the next 2 years. And so that's been one of the things that I've changed in terms of my management for my patients in regards to lots of things, but specifically also cholesterol. So I think that's been a helpful one.
So long as the patient can avoid that prolonged, like if someone who's smoking 3 packs a day, who had a heart attack last week, who is diabetic, I mean, they probably need to be on a statin right off the bat. It is my personal bias, but yeah,
I mean, that's a good question. Do they? Do you have 2 years? I don't know. Like, what is your thought on that? Like,
I think that their risk of disease is in the 10 years is greater than 5%. I mean, a recurrence. Although, interestingly, 50%, about half of recurrent ACS have normal LDL levels at the time of another coronary syndrome event. So, but I mean, I think in to me, that person needs to be on a statin. But that's, I don't get,
and I think, this is probably one of the things we get selection bias. I don't get a lot of those patients in my clinic, right? You don't,
we don't get a lot of them. Yeah.
You don't come to me for the most, and that's not exclusively true. Like I have some severe alcoholics, severe obese, liver failure and things like these. They're rare in my clinic because you don't come to me looking for a quick fix, most likely, in the primary care health side of things, because I don't advertise. So you're referred by somebody that was already in my patient base. And so that scales of difference become smaller and smaller. You're not going to, somebody who works out at my gym most likely and regularly works out and takes care of themselves likely to a certain degree doesn't hang out with someone who smokes and drinks and is obese and has diabetes and all the risk factors.
Interestingly, how I would frame that is I agree with what you're saying about the 2 years. I agree with the concept of Kaizen, small incremental changes. I agree with all that and making sure consistency is the goal rather than some arbitrary number, etc. I would use the reverse of that too. the corollary, the flip side, so to speak, for the patient who I just said you need to start statins immediately. Perhaps you start on a statin immediately until over the 2-year time frame. Now they can get off the statin, right? I think a lot of people get on these and they just stay on them forever, no matter what.
That's a
and
good
then
point.
say, okay, we're going to over the next 2 years change or engage in aggressive lifestyle modification, and then perhaps at the end of 2 years you're off. You're not your your A1C is 5.0. You're no longer smoking, no longer drinking. You're starting regular exercise. You've lost 10% of your body weight, or at least your excess fat weight. You're working out, and then all of a sudden, look, now your risk is so much lower from a relative standpoint that you can be off of statins because they don't confer that much benefit to you now to outweigh whatever the perceived risk is. Perhaps not. I'm just saying
that's a good way to do it. I've been framing semaglutide use in that same that same paradigm is like, yeah, I don't want you to be on this forever. You don't need to. Maybe you are, maybe you aren't. But let's not think of it that way. Let's think of change over the next 2 years. This is part of that driver. This is part of the early wins. This is part of the psychological side of it. This is part of a piece of a puzzle. And now you fit the other pieces, and the exercise gets bigger, and the diet gets bigger, and the community gets bigger, and the stress reduction gets bigger. And maybe then the semaglutide takes a back seat. And I don't think I ever framed statins that way, but that's an interesting perspective. Maybe for somebody like somebody who has been using gear, maybe somebody who is in a state where it's a problem due to lifestyle issues, maybe we could use statins in that short run. It'd be interesting. I don't see it used that way so often, but that doesn't mean it can't be used that way.
Right. I don't either. But it's interesting to think about. What does statins do, Chester? What is so great about statins, and why are they so popular? What are they doing?
Well, essentially, they're going to reduce
just a thumbnail sketch.
Biosynthesis. They're going to reduce how much cholesterol you're going to make. So we have certain sort of proteins in the cell that talk to each other, and it's sort of a pathway that leads to eventually the production of cholesterol. And statins are going to inhibit the HMG-CoA reductase enzyme. Therefore, HMG-CoA is not going to be converted into malonate. And this is very important because we have exogenous cholesterol from our dietary intake, and endogenous cholesterol, which is all the cholesterol we make, and then about 70%, maybe numbers are a little bit skewed if you're a bodybuilder cranking out high protein every meal, animal protein in particular, but about 70% of the cholesterol that we make that's in our total body is going to come from the cholesterol we make. So let me rephrase that. About 70% of our total cholesterol is going to come from the cholesterol we make naturally, and statins are going to limit how much cholesterol we naturally make. Therefore, we're taking out a very large chunk of the production of all the cholesterol in our body because we're going to limit our endogenous production of cholesterol. And this has led to maybe 30% up to 50% of your reduction in LDL, potentially even higher if your doses of statins gets higher, maybe up to 60 or 70% of your LDL cholesterol. If you nuke that, your disease risk also attenuates.
Mm-hmm. Yeah, I think they're quite effective. That's because
quite
they affect
effective at doing what?
Well, because they're affecting that 70%. They can be quite effective because they're affecting that 70%. Whereas I see some people do lifestyle stuff, potentially, only affecting that 30% side of things, and that can become frustrating for the physician as well as for the patient if they're like, "Well, I started walking and my cholesterol didn't go down," and so I think that's probably leads to some of their reason why they're used so much. But they also carry some side effects, right, Jason? I mean, they're not free of charge, as is nothing in medicine.
Yeah, absolutely. I mean, I think they do give you a way to address the 70% of cholesterol that's endogenously created instead of diet. And then, but the question is, the devil's in the details. I mean, what is the absolute and what's the relative risk reduction for coronary events, and what are you going to have to go through to get that? It is a kind of a point of contention for a lot of people. So some of the downsides are myalgia, myopathy, liver enzyme elevation, myositis. It's a chemical hepatitis is what it is. I mean, it's not a viral hepatitis.
Oh, interesting.
Well, that's what it is.
I guess I've never heard of it said that way.
You could say hepatopathy, I guess you could say, isn't it?
Yeah. I think it's more common than the research says. I mean, the research always points to how low it is and how unique it is. And I hear it quite commonly, the muscle aches.
I do too. And not to mention coenzyme Q10 production, which is one of the most abundant and powerful free radical scavengers. I mean, glutathione is maybe a little bit more powerful, but it's up there, ubiquinone. You get lower levels of that. Golly, man, it's tough. I think you got to look at the whole picture, and you got to focus on the things that are a win-win. It's a win-win to do more exercise. It's a win-win to change your diet. It's a win, and like, I went down this road myself with statins. I did way better changing my sleep, my diet, my exercise, my nutrition, and optimizing my testosterone than I did on statin therapy, period. And now I'm N of 1, but I mean, it's got to be individualized to each person, their unique set of risk factors and what they choose not to interact on or change. So, but it's just not the panacea. I have not seen it be the panacea that it was hoped to have been.
Of course not.
So the question is it because it's not, or are we looking at the wrong biomarkers, and are there other ways to reduce ApoB rather than just LDL?
And my fear for that ApoB train, which I'm a little on, and so are we just doing more of the same? Are we just going down the failed route even further and we're following a flawed line? We're following it further down and we're getting better with it, but it's still a flawed line. I don't know that when you look at those big things that cause cardiovascular disease, and we're just picking one of them that is easy for a physician to manipulate and easy for a patient to then manipulate, like we said in the last one, just taking a pill. It just makes it so simple. It's really hard for me as a physician to, in 5 minutes of working with you, to, if I was in a standard practice, to get you to exercise. It's really hard in 5 minutes to explain what eating right is, because I'm probably not doing it myself. And it's really hard to get you to stop smoking. It's really hard to get you to stop drinking alcohol. But it's really easy just to prescribe you a statin, and really easy for you just to take it. So it is like the thing, it is the hammer that every physician has at their. So I think that's part of why, even if it's not the best, which I don't prescribe them a lot, I think it's probably the least common prescription that I do.
Here's an interesting stat. In this paper, this review from 2022 out of Harvard. It's just a review article on ApoB, but it cites some other studies. CVD risk reduction achieved, and this is historically, via lipid lowering therapy in most clinical studies, I'm quoting, does not exceed 30%. So what are we doing? So that harkens back to what you're saying. Are we still looking at the chicken when we should be looking at the egg? I don't know the answer to that, but I know enough to say it needs to be a question, and it needs to be, and you got to think of it as a broader scope. But it's very hard in a managed care setting, as well as and frankly, people that don't want to listen or change their habits. You do what you can do, and you're right. It's easy to take a pill, but it's also easy to prescribe one. People seem to be more adherent to that than actually changing their lifestyle and doing those things that they need to do. I don't know. That's the. What say you, Chester? How are we going to ever get people to change their lifestyle and modify their other risk factors?
I think, and I'm just a consumer, right? Obviously, we tell people to eat right, but I don't know if you guys, you've gone grocery shopping and you went and bought some vegetables, but it's a healthy chunk. If you want to do vegetables every week in high dose, you're spending $50-$100 just on vegetables, and you add some fruits and you add some healthy oils, your extra virgin oils, because they have a little bit higher polyphenol content than your refined oils. You could be stacking up some big bucks in terms of what it takes to eat right. A couple $100 extra a month. Whereas if you have a statin covered by your insurance, what are you paying, like $12, $20 a month?
Yeah,
So
but what are you paying by not doing it? I hear this excuse to the gym all the time, and I'm like, yeah, it's expensive. It's because you're buying a pack of cigarettes and you're not worried about that cost, and you're drinking some alcohol and you're not worried about that cost.
You're both right, because it's what do you put your
on
emphasis on,
consumer.
right?
Yeah,
do you put your emphasis on saving money from food, or investing in yourself and reaping the benefits of that in the long term? People are always worried about the short term.
Yeah, I always pay the money for food and invest in food, but like, what can we do? Like, as a society, we need to have a shift away from our big pharma. Let's get them rich. Like, okay, let's make it easier on the consumer to access more affordable fruits and veggies, to give them the education they need to get the highest quality dietary compounds that they can get. So I feel like there has to be more of a societal shift. We see that with
here's you want to know, I was thinking about this on the way to the podcast today. You know how you do this with what you guys are already doing, and what you're seeing is people have a tribe, people have a local. We don't rely enough on our local networks. So if you think about, Chester, your followers and the people that listen to you, that's a example of your tribe. Jeff, your Midtown medical family, us three together, the Vitality Telehealth community. And if you have these local communities where you're coming together, let's say you've got a Midtown medical, that's the hub, and then there's spokes out from that, right? So there's a branch of this. It needs to be developed. I mean, it would be slow, but it would be a good process. I mean, it would be a worthwhile process where you team up with a local area farm, and you're sourcing fresh vegetables and everything, and then so it'd be nice to have these interconnected networks instead of everybody just relying on the government or these big slow moving agencies or big pharma, big government, big this.
You know what we need? We need a big exercise cartel instead of a big pharma cartel. What if we had? God, watch out for big exercise. They are out of control. They're nuts.
Damn you, big exercise.
Big celery market's coming after you, man. I tell you what.
Oh man, big celery's coming.
that big cucumber farmer. Woo.
Oh man, those guys.
I mean, it would be interesting to see the amount of money spent by pharmaceutical and advertising and the money spent by big exercise. Like, even if you say, oh, it's silly to go to these $10 gyms, they're just taking people's money. But like, what are they spending in their marketing budget compared to what Pfizer spends in their marketing budget? Even if just, the old Gold's Gym of America was just this huge, massive monolith of American culture that just influenced every decision, and every commercial you ever watched was about exercise and different exercises. It would be interesting if we could have a huge framework shift, instead of every time you watch TV, every commercial is about a pharmaceutical. It's hard to get out of that setting.
I do think people are getting more. I don't know. Maybe I don't know what's reality. It's just hard to determine what reality is. What your reality is versus. I mean, but it seems like
things are changing. We know.
Internet and social media, and there's more information available. It might not be high quality information. It can still be manipulated. So you have to be careful there. But it's definitely talked about more than like think about 2-3 generations ago. They didn't talk about this stuff openly, or they didn't understand. The average teenager probably knows more about cholesterol than 89-year-olds or the generations of yesteryear. So maybe that's where it is. I don't know. So if you're not going to use statins, what's our next line, guys? What are we? So we think about niacin for HDL, raising HDL, although it's got flushing issues. You're thinking about fenofibrate for triglyceride reduction. You're thinking about fish oil, 4 grams a day for triglyceride reduction. What else, Chester? What about peptides? So is there a class of medications involving these? Everybody loves talking about peptides nowadays. I mean,
peptides can have a number of different functions. Peptides are essentially just smaller proteins. So we have, amino acids, which are the building blocks of proteins. Peptides are typically just smaller proteins, 2 to 20 amino acids just kind of linked together, and they can have numerous effects on your body. Some very powerful antioxidant effects. If we're going to look at something like glutathione or carnosinase, or potentially L-carnitine, which you may have heard of some of these peptides. In particular, glutathione. It's considered the mother of all antioxidants, and we have some really good data that essentially says the lower your glutathione is, the poorer your health state is. And we even have some data on CVD in particular, cardiovascular disease, that says the lower your glutathione, the higher risk you are for cardiovascular events. So glutathione is a big one. And you can get this a little bit with some various dietary intake, but some of the bioavailability might not be the best if you're going to try to intake, the necessary amino acids through diet. So people have turned to the injection method of glutathione, and that might be sort of the new treatment, if you will. Kind of the statins, maybe the old school, glutathione, and maybe the shift towards preventative medicine, this antioxidant focused approach where you can maybe prevent that endothelial damage from occurring. That could be, driven by higher antioxidants in particular. Glutathione might be, one of the new peptides that we're going to continue to explore within the literature.
Yeah, it'd be kind of cool to see if we could do a large-scale study. But I don't know that it would ever happen, but a large-scale study on glutathione and endothelial health markers, antioxidant markers in reduction of cholesterol. One of the great ways to increase your glutathione is exercise.
Absolutely. Yeah. Low impact. Yeah. Yes. Induces the liver to produce more, and you like low impact cardiovascular exercise increases antioxidants endogenously in the body, and glutathione is a big part of that. Absolutely, it is.
We use glutathione for IVs quite frequently. That's one of the more common ones that we include in people's IVs, as well as vitamin C if you're talking about antioxidants. But glutathione specifically is one of the more popular. Injection as well. It's not that expensive either. I think it's good for that reason also.
I got a question. One of the side effects of glutathione is sort of a yellowish, reddish tint to your skin. How often do you see that? Because in the literature, that's, the hyperpigmentation is kind of the big side effect with glutathione, the big downside, if you will, if you don't want to have that sort of tinted skin. So I'm just curious, how often?
I've never seen it.
Okay. Yeah.
Yeah. I wonder.
I've never seen it, but I don't prescribe it a lot either. I never use it.
I imagine it's probably someone using quite large amounts.
So I feel like they underreport the negative muscle side effects of statins. It's only
100%,
3%, under 3%, and they maybe overreport, some of the glutathione side effects in terms of this hyperpigmentation of skin. That's interesting what the literature does, and obviously the literature. If you're doing a research study, you want to please who funds you. That way, they keep funding you. So some of the data might be a little bit skewed in terms of its presentation to please the donors or the funders of the research study. So you might see some more, pro-statin things or pro-big pharma, and maybe less some of these nuanced medicines, if you will, nuanced peptides.
Yeah, I mean, it has to influence it. I always think back to that one, I saw a little diagram, and it was like new research comes out, and then arrow to the right. The research agrees with what I think. Next arrow, research is great. New research comes out. Research doesn't agree with what I think already. Research is flawed. Here's all the reasons why it's flawed. That's just human nature. It's hard to be objective. But I think one of the things we talked a lot about statins and some of the peptides, but there are some other drugs as well as some lifestyle measures that I think would be good to explore. And maybe we can talk about those in another episode, going down some of those specific lifestyle whatever I'm trying to say, lifestyle factors, modifications. Thank you. That will help improve your cholesterol and your endothelial health and reduce your inflammation. So if people don't want to use statins, what are those other things that they could use? And that would be good for us to go over next.
Yeah, that'd be good. Yeah, because statins are considered, we're in the era of statins, but there's this new drug, the PCSK9 inhibitors, and I think we're going to enter the era of the PCSK9 inhibitors very shortly, if not already within the past years. Jeff, was I the first patient you ever had to do Repatha?
It is. You were. Yeah.
Yeah. I remember we did that injection.
It was a pain in the ass just to get it through insurance. It was such a freaking hassle.
Because that's a good story to tell. That's one of the downsides. Why are statins so used? Because they're so easy to get. They're cheap and easy.
I get pressured from insurance companies to prescribe statins. That's how much They send me letters like, hey, we saw that you are managing their diabetes with a drug. Do you know that they're commonly combined with a statin? Why aren't you prescribing a statin? That's how much they're, and I was like, what? That was weird to me. And then when we tried to do Repatha, I hit with roadblock after roadblock after roadblock.
Well, yeah, they look at it's where actuarial science intersects with corporate profits, and they're gonna be looking at what they think is their biggest bang for buck for risk reduction. But
it's always about the dollar.
Dollar bills, y'all. Well, hey, this has been good, guys. I appreciate your time. You've both been generous with your time, and let's come back and meet up again on this series on cholesterol and see what we can figure out and find out about, other treatment strategies besides just these statins, which may or may not be the right thing, depending on the case. So, what do you guys think?
Let's do it.
All right. Good seeing you guys.
All right.
See you later,
See you,
everyone.